Welcome everybody. This is an exciting WebEx in our series of Lunch and Learns because we've been waiting a little time to do this one, and I think it's probably very opportunistic with the time of year, etc. So I think, you know, putting care homes at the centre of support for long-term conditions for me is really important. So I'm looking forward to hearing this presentation and joining in the discussion at the end. So in the first instance, welcome. Nicola, you have a little bit of background noise behind you, but just to welcome you to our WebEx and to let you introduce yourself and to the session. So welcome.
Thanks, Bev. Sorry, I couldn't find a room, so I am in an office, so I'll try and keep the noise to a minimum. So just as Bev said, I'm Nicola Spencer. I'm the Programme Support Manager for End of Life Care, working in NHS England in the Medical Directorate. And I'll just set the scene a bit for you all, and then I'll hand you over to my colleague Emily Carter. Okay, so just to set the overview for the work, we've been working with partners to publish a series of quick guides to support local health and care systems. So the purpose of the guides are really to provide practical tips, case studies and links to useful documents which can be used to implement solutions to commonly experienced issues. So the information can be used to manage upcoming winter pressures and also to support planning for 2016 and beyond as well. So the quick guides, really, they can bring clarity on how best to work with the care sector. They can help people to find out how to work across the country and to find out how others are working across the country with the care sector to reduce unnecessary hospital admissions and delayed transfers of care. They can break down some commonly held myths, for example, sharing patient information across integrated teams and continuing healthcare assessments. They can also allow you to use other people's ideas and resources and also enable you to break down some of the barriers between health and care organisations. So the quick guide that we're going to talk to you about today is called Clinical Input into Care Homes. And as Bev said, the slides are going to be circulated, so hopefully that link will work. So just to give you some facts and figures before we go into the detail behind the guide, I thought it'd be useful to set the scene in terms of what we know about this complex cohort of patients. So the majority of care home residents are living with complex comorbidities. Over 75% of those living in care homes have dementia and severe memory problems. The median number of medications is 9 per resident. 2/3 of the residents are immobile or in need of assistance. The median period from admission to care home to death is actually 15 months, which is quite a shocking figure. And 20 to 30% of ambulance calls from care homes are due to falls in the elderly. So we know that people in care homes and nursing homes often experience difficulties accessing the right care at the right time. And obviously these people have the same rights to care as the rest of the population, but they frequently suffer inequity around the services provided, and this really needs to be addressed. So improving the clinical input into a care home and tailoring care around the diverse needs of an individual's resident can really improve the quality of care and the quality of life of people and reduce unnecessary hospital admissions. I'm just going to hand over to Emily now, who's going to talk to you a bit more specifically about the quick guide that we've presented, that we've developed.
Hi there, everybody, and thanks for joining us. So obviously, Nicola set the scene that, you know, there's massive inequities and really big health issues for people living in care homes. And at NHS England, we do have a large piece of work with the care home vanguards looking to the future and how that care can be provided. But we were tasked with what can we do more quickly, and this was at the end of summer last year. So what could we do before winter to really support care homes and care home residents? And so that was why we decided to develop a really practical guide aimed at commissioners and providers and everybody working with care homes in the health and care sector, which is full of ideas and examples of interventions which could be introduced relatively quickly and lots of resources to support people to do so. Can I move on to the next slide, please? We worked with a really diverse range of stakeholders in putting together this guide, and if when you go onto the guide on the website, you'll see the long list of actual contributors to this. But we worked with NHS trusts, We work with NHS trusts, voluntary sector organisations, care home providers, local authorities, CCGs, academic health science networks, patients, and a huge range of national bodies such as the British Geriatric Society, the National Care Forum, NHS England, Registered Nursing Home Association, the Alzheimer's Societies, local government agency. I mean, I could go on and on. It was a huge number of people who got involved, and also who have really generously shared many of their resources, which we've pulled together into this guide. But what we were doing with those people was to hear about what is working on the ground and to really understand why it's working. And that's what we've pulled together in what is hopefully a very easy to use guide. We focused the guide on several different areas. A lot of the sections you'll see were broken down into kind of specific conditions and particular specialities, but some of the most important sections are actually where it cuts across all healthcare systems. So the work around how we work better together within health, so building effective relationships, are where people have reported some of the biggest impacts on improving care for people within care homes. And there are loads of examples of how people have done that, but very much about health and care systems working together, using some of the resources which we reference to try and really improve ways of working. Again, multidisciplinary team working is where we've had some of the biggest reported impacts on care, and you'll see within the guide that we have Leicester who've reported 60% reduction in admission costs for the work that they've done with their MDTs. And I won't go through all of the different sections, but we have so many different examples of interventions, initiatives and ways of working across pretty much everything that you could think of within care homes. And as I said, they're really quite jam-packed full of useful resources, and we've referenced a couple of those useful resources there, which, for example, Cornwall have shared their whole suite of clinical management tools, which they've developed specifically for care homes. I think there's something like 18 different tools there, which people are able to download and adapt for their local use. We have people who've shared service specifications for schemes that they've introduced. And again, we're so grateful for people for sharing these resources, because it will make things much easier for other people to pick up and replicate elsewhere, and saving some of that work. We are going to go into a bit more of the detail of some of the initiatives detailed within the guide, but I just wanted to quickly share with you some of our next steps here at NHS England in terms of the work that we're doing with the care homes sector. Obviously, I mentioned the care home vanguards at the beginning, and that work continues, and we're going to be doing some work with the vanguards to try and share some of the early learning and some of the early models which are coming out of the vanguards more broadly, but we aren't expecting for the full modelling work to be complete for another year or so. We have set up an independent care sector programme at NHS England and are developing a really detailed work programme for the next year, and that's going to continue to produce some more guidance and going into a little bit more detail on some of the areas where people have told us that they would like some more information. So, for example, around upskilling staff, that's an area that people thought would be more useful, some more work around technology, and various other pieces of work which we'd be very happy to share with you. But we're delighted to be able to have some of our colleagues who feature in the guide with us today, and I'm going to hand you over to Angela Dempsey. Angela is a nurse and midwife and has recently worked at the Leadership Academy creating the Edward Jenner programme. And Angela also worked for NHS England in a regional team leading on patient experience. She's worked on CCG as a governing body nurse for over 3 years, and now works 1 day a week in a CCG and 4 days as a clinical consultant. So she has a huge wealth of experience and knowledge, and will be talking about some work that she's been doing. So I'll hand over to Angela now. Thank you.
Okay. Okay, Emily, no pressure there. So I'll introduce myself. So yeah, I'm Angela Dempsey, and I am a CCG governing body nurse, and that's what I've been doing this morning, chairing quality and safety. And I'm also their exec lead for long-term conditions. So this is fab for me because it's some real information I can bring into my own CCG. So a little bit about Quest for Care and the reason behind it. Firstly, I was in an NHS England role, and at the time I had no data on care homes really. I didn't know if they were good, bad, ugly, indifferent. I had no idea at that point because I had nothing to capture that information. And as a governing body nurse as well, I was doing an MBA, and part of that I interviewed 72 chief nurses across the country to ask them what they thought about care homes, and that was what was keeping them awake at night. It wasn't that they thought all the care was bad, but they just didn't have much to assure themselves that they knew where their care homes were and what they actually offered. So that was actually the thrust I needed to do something. And so I wanted to create something with care homes, and I knew at the time I was unable to do that in NHS England at the time. So I took a leap of faith and I left the NHS full-time, well, 4 days a week, and I joined RSM, who has a really big software arm to the company. So what I did was I worked with the Vale of York Clinical Commissioning Group and a whole cohort of care homes to develop Quest for Care. So in terms of why, a bit about why I really had a passion about it. I was working in an organisation that specialises in audit and risk and governance, and I just knew that if we were able to share a little bit more about what was going on in the care home sector, it'd be really good for care homes and also for commissioners to understand more about the quality and safety, and also to create that collaborative conversation which wasn't actually taking place with care homes. They really weren't being brought in to the fold. So that was really why I wanted to create Quest for Care. So, hang on, I'm just having a bit of a struggle clicking this forward. Come on. Okay, here we go. A little bit about our RSM, massive company, it provides lots of risk, audit, software solutions, and we work very closely with the private sector, public sector. So what is it? Well, in essence, the most important thing what it is, and it's very easy to understand, it's a self-assessment questionnaire that can be accessed on a PC, smartphone, tablet. Very easy. You could start it in the office, finish it while you're doing your dinner in the evening if you had the information close to hand. So it's very, very flexible. The thrust of it is there's an intelligent branching of questions. So if we ask a particular question, it will bring you down a particular route. There's also questions there that ask for a qualitative narrative, and there's also questions that ask, do you need support? So I'll come on to that a bit further on in terms of when commissioners have asked, do you need support with a particular thing? The care homes can come back and say, yes, we do. Please, you know, we really want to be part of this. The other thing is it links to national good practice and websites. So what I've done is I've been very mindful to link to the Leadership Academy. So, for example, all the free online courses that they can do if they're providing continuing healthcare, so for funded NHS places. Also local policies. So, for example, lots of the smaller care homes struggle to actually get so up-to-date policies, and what we've done is work with commissioners to say, this is in the tool, it goes straight to, for example, down in Somerset, straight to their continence policy. So it's actually the care homes are looking around for stuff. Also, we link to NICE best practice too, and in fact I'm meeting with NICE on Monday because they really like what's in the tool and they hope to accredit it. Each of the questions are RAG rated. So we have a RAG rating there. The scoring actually I did in co-production with a lot of care homes, and they were quite harsh on themselves, I have to be honest, but it's something that they like and the commissioners like also, so that's within the tool. And the tool also allows for comparison against cohorts of care homes to help improve the standards, and also it's very easy to report. So, for example, if I wanted to produce something from my Quality and Safety Committee or for a governing body, you can lift and shift the information out really easily. So these are the areas that the questionnaire looks at about the care home, safety, effectiveness, experience. Now, the final one is a compassion and practice section, which I co-wrote with NHS England. It's very new to the care home sector. To be honest with you, I didn't know how well it would be received. Some of the care homes love it. Some of them don't love it so much because it's not so familiar with them, but the commissioners like it because it gives that qualitative, softer element of care. So we really drill down into what's important for residents, for them on a daily basis. So that's another section, but we score that quite lightly at the moment because we know it's quite new within the care home sector. So this is what it looks like. So the person fill it in, it's dead easy. They can bookmark the page, they can go forward and back, they can save. We have an index facility. So alongside this is a crib sheet. So it says, I'm going to ask you how many students you've got. I'm actually going to ask you how many registered staff you've got. So the crib sheet will say every quarter, this is the information I need to hand. So we look at the main things like resident flow. We're also looking at inspection regimes. Most importantly, I've asked questions around students because I personally think this is really important. I've spoken to 100 care homes. I would say 5% had students, which in terms of capacity in the future, in terms of the strategy for community nursing, I think this is something we need to be very mindful of. And I have fed this back to Jane Cummins' team through Hilary Garrett. So we very much focus on the things that do make a very good home. In terms of safety, again, the usual suspects you'd expect me to have in there. But what I have done is I've actually put a section in about hospital avoidance. So that promotes a conversation between the care home manager and the staff to say, Doris was admitted on a Sunday at 11 o'clock at night, but Doris returned home at 6 o'clock in the morning on the Monday. Did Doris really need to go into hospital? Was there anything we could have done? Were we linking into out of hours? Were we linking into any community services that provide rapid response? You know, actually looking at these admissions and seeing where they could have been avoided. So there's real strong sections on that. Again, the commissioners like this section, and the feedback from the care homes is they like it too. They like to have that conversation, and also they like to be able to justify why people went into hospital. There's also what we do is we do focus in on end of life as well. In terms of effectiveness, and what I would say, this tool is only one part of a bigger conversation. It's about triangulating with the soft intelligence from GPs, district nurses, residents themselves, and also the family. So this tool cannot be in a standalone tool. It will give you so much information, and it will also track. So, for example, over a year period, you might actually see where a home is deteriorating, and you can pinpoint when you need to go in and what actual you did to support that particular home, because often through the tool we ask, do you need support? Is there anything you want to say? So in terms of effectiveness, we have a whole questions on policies and protocols. Again, signpost to local policies. So, for example, we know down in Cornwall there's particular policies they've put in the tool. We ask questions on induction and ongoing training. So what I have done is I've asked questions, for example, around end of life, for example, VTE policies. So for those residents that went from mobile to immobile, and what we have been able to do is share them particular policies across CCGs. So, for example, York have just shared their policies with Somerset. We've also pushed them a little bit further on individualised healthcare planning, and anything which is current and it's contemporary at the moment is within that particular tool. I'd like to say as well is in the initial stages we were thinking that this tool would only be used for nursing care, but we did pilot it in local authority homes, and there was only 6 questions that they thought was a bit too nursey, a bit too focused, but in actual fact they were happy to answer. So the questionnaire is being used in hospices, local authority homes, homes for people with learning disabilities, because it very is about quality, safety and experience. Again, this section is about resident feedback. What we have done as well, there's a strong section on staff feedback about whistleblowing policies, that sort of thing. And as a response, some of the homes have actually realised that they're not doing much, and also maybe even gone out to and had external people looking at their complaints. Because often the care homes we've worked with have looked at all of the complaints internally, especially if they're not a big consortium, the likes of Barchester and Bupa. So very much that learning stays within the organisation, but they actually don't know if that was the right learning at the time. So these are the questions that we ask that prompts that qualitative question between the commissioner and the care home itself. So in terms of compassion and practice, as I've said again, within it, what we've done is it isn't so cut and dried. What I've done is I've graded it, so the answers are strongly agree, agree, disagree, strongly disagree. What I would say is the reason I wanted this section in the tool is when I first had a dream of doing this, and I sat with some NHS directors in the CCG, they promptly told me that care homes would lie. Angela, they wouldn't tell the truth. And my response was, well, every month I receive information from acute providers. Do they lie? I commission them services, but do they lie to me? So the reason I put compassion and practice in is because it balances out. So if somebody's saying something at the beginning of the tool, there's questions at the compassion and practice section that if they answer differently, it wouldn't match up. So, for example, around loneliness and saying they have activity coordinators, also they're looking at personalised healthcare planning, and they don't actually have a name designated lead within the care home for a particular resident. So some of the questions do balance out. So, hang on, let's get my button clicked. So in terms of the questionnaire, these are some of the things that have been some quick wins. And what we have done, especially in York, what we've done is in terms of the care homes resilience, we've had care homes now that weren't on the radar as being exemplars of good practice. And they are now, and they're offering reablement care. So, for example, the residents leave the hospital. Well, patients leave hospital, they go into the care home, they get rehabilitated with intense OT, physio, and then they go home. And the quick win is the staff in the care homes love it. They really love to see people come in, get better, and go home. So there's been some great wins. Also, we've worked with some CCGs to try and start offering more student placements, obviously working with their local HEIs to expand the placement circuit, because if commissioners don't know that they're places of excellence, then they're not going to be encouraging students to come and learn there. And one of the things I would say is, having spoken to lots of care homes, nurses in care homes are so autonomous. And recently I spoke to a newly qualified, I'll say newly qualified, she's been qualified about 18 months, and she went straight from qualification straight into a care home, and she says to me she's autonomous because she's looking after all of the people in nursing care all of the time. So they can be amazing places to work and also to train. So that's something that the tool is giving information back to commissioners to tell them that. So in terms of York CCG, they've worked it into their care home forum. NHS Care now, at the time of me doing this, it had a 90% response rate, but in actual fact it was 100% response rate. And they've got a peer group going on now. They've got a buddy system. So what they did is they've gone in at smaller cohorts. So they've gone a small cohort of homes first, then the second cohort, and then the third cohort. So NHS Care now have had 100% response rate to that. So in terms of next steps, we're working with NICE, so I'm meeting with them on Monday, and they're going to look at the tool again. We've actually developed the tool to work in NHS England's immigration detention centres to capture patient experience. So that's we go live next week, and the Queen's Nursing Institute, the Chief Exec's really interested in working with us so that they can actually get access to care home settings. And this is something I hope I'm able to do, and with buy-in from the care homes, I want to be able to offer a link from the tool to residents and to their families so they can actually put in some information that they think about what care is like for them and for their residents. And also what I would like to do is put some more information on the Frailty Index tools for the care homes so that they can actually utilise that as well. So, in terms of management report, which is really important if you have to report on stuff, very easy. You can lift and shift it. You can make comparisons of homes locally. You can do it regionally. You can actually say, for example, I want to look at care homes, nursing care homes, the bed base of 50. I want to look at their pressure ulcers, and I want to look after the year. I want to look at the top performing 5. I want to look at the worst performing 5. And you can actually take whatever you want, look at the KPIs, which KPIs you want to choose, look at staff and that sort of thing. So the tool itself is really easy to use, it's flexible, and next week I'm off to meet with Somerset again with the care homes just to find out how they felt it was for them, and also if there's things I need to change. So really what I'd like to do is keep it contemporary, work with the care homes as they're evolving and adapting, and also, if need be, put in more stuff into the tool, links, information, so that it makes it much easier for them to access information. So that's the end of my presentation now. No, well, I say that, nearly finished. Just to say, if you wanted to look to see in terms of the RAG rating, you can see the questions, which KPI, and it will tell you how many homes were red, how many homes were amber, how many homes were green, and that's really important for a CCG or a local authority to give an overview of what their care home stock is like, so that they can actually look at system resilience and think, you know, where can we put resources to obviously support delayed transfers of care. So I do actually think that is the end of mine. So yeah, I'm just going to show you some quick dashboards, but I know we're mindful of time, so I'll just go back quickly hang on to that. So again, this is an individual home plus a peer group, so we can do lots with the tool. What we tend to do is we train up the administrators within a CCG local authority, so that a senior clinician can just rock up and say, do you know what, I need to know about end of life for this year. I want to know how many people died in their preferred place, and also, for example, emergency admissions, what were they for? Was it for pneumonia? Was it for falls? That sort of thing. So the tool itself can pull off whatever people want, and also a CCG can add in questions. What I'd like to do is keep the core questions the same, so that we can benchmark nationally, but in actual fact, for example, Sefton have put lots of questions in around continence, so keeping residents continence, that sort of thing, but that's very personal to Somerset. So I know that was a wishful stop tour of mine, so I'm just mindful of time. So, and I know we've got questions. So what I would like to do now is I would like to hand over to my colleague, Dr. Dawn Moody, who is going to give you an amazing presentation. I read it and thought, my God, this is just fantastic. Why aren't we all doing this? So Dawn is a GP with special interests in the care of older people. She's also a frailty lead for West Midlands primary care workforce, and she's also set up a company called Fusion 48, which I'm really interested in. So I think we're going to enjoy this presentation, and really pleased to present Dawn Moody and her overview of the Frailty Toolkit and training programme. So over to you, Dawn.
Thank you very much indeed, Angela. That's very kind of you. And thank you, Nicola, Emily and Bev, for the opportunity to join the webinar today. So as Angela said, I'm going to tell you a little bit about a programme that we've been working on in Nottinghamshire, which is all about developing a toolkit to support professionals to support and enable people with frailty across Nottinghamshire to self-care. So these are some of the things that I'm going to cover in this presentation and giving you an overview of this project. And the first thing that I'd just like to tell you about is a very brief bit of background to the project. So the background to this project was that it's a project that's been commissioned by Health Education East Midlands, mindful of the fact that there are around 20,000, or there could be estimated to be around 20,000 older people who are living with frailty across Nottinghamshire and Nottingham. And the reason that we're talking about this today is obviously because many of these people will be living in 24-hour care settings, either in residential care homes or care homes with nursing. And this project is featured in the quick guide in relation to the section on how to support and upskill staff in care homes. Because this project in Nottinghamshire was about the whole health economy. It's about everybody who works with older people in health and care in Nottinghamshire and Nottingham City. And it came about because there was a Health Education East Midlands, the Local Education and Training Committee held a stakeholder event to identify some key local priorities that were linked into national initiatives around the care of older people with frailty. And the areas that they identified were that they wanted to have a multi-agency and multi-professional approach that would be all around integrated assessment and around consistent education and training standards, and that would help professionals to enable people in this population group to self-care. So it was all about enabling supported self-care for people with frailty. So the objectives So the objectives of the project and the requirements, if you like, of the phase, what were we asked to do in this really exciting project, was that we were asked to research, design and deliver a multi-agency, multi-professional toolkit that would support and enable health and care professionals to take a consistent and evidence-based approach to supporting self-care for older people with frailty. And there were two parts really to the project. One was about developing a toolkit, and one was about developing an innovative education and training programme to launch the toolkit to participants across Nottingham City and Nottinghamshire. And the objective was, before the end of March this year, the project started last summer, was to offer this training to 400 people across the health and care economy in the Nottinghamshire area. And as I say, the really important thing was that this project was open to absolutely everybody. So it was open to people working in acute trust, to people working in care homes, and to people working in every single setting in between. Also open to people working in voluntary sector organisations. So it was quite an ambitious brief and quite a challenge, but certainly a really, really tremendously enjoyable project to work on. And I'd just like to tell you briefly about some of the distinctive features of the programme and some of the things that we did to try and achieve the objectives that were set out. So really there are 6 main things that I'd like to tell you about the project, and there are lots more resources available on the project which I can tell you about at the end. So the first objective was to develop the toolkit that would allow professionals to support people with frailty to self-care. And we decided that we'd like to do this through an app. This is basically an app that's accessed through a web browser, so it can work on any platform. It is optimised for smartphones and for tablets, but you can equally well access it on your desktop. So it's an easy to navigate toolkit. It's got lots of resources around frailty and around supported self-care. It's divided up into different sections. We've got what we call the learning zone, and then we've got other areas called the enabling zone, which contains planning templates. There's a directory of resources, some of which are local to Nottinghamshire, but some of which are also linking obviously to national resources and resources on a wider scale. And then we've got some case studies, which I'll tell you a little bit more about later, which demonstrate the practical application of some of the skills and materials that are included in the toolkit. And as I mentioned, you can access it basically at any time for learning, for practical assistance, and to help you in the work with people with frailty. The second key feature of the programme was this approach that was very, very strongly around multi-agency and multi-professional teams. And so we have full-day training events where really the first thing we do is to work through some of the skills around understanding frailty and understanding supporting self-care. And then in the afternoon we develop those skills to apply them to some case-based learning that we've developed. But the key thing is that we've got people from across the whole of the health economy coming along to these events. And we've organised the tables so that people work in teams for the whole day in a multi-professional and multi-agency team. And the themes of supported self-care around empowerment, motivation and capability building run through the whole session. So as I say, in the morning we focus on understanding frailty and skills for supported self-care, and also a very important piece of work where we look at helps and hindrances to joint working, so the participants involved are able to work through some of the issues that they encounter in their daily work. And obviously it's very helpful to have the opportunity in that setting to share those with other colleagues. So for people who are working in care homes to understand more about the challenges in other settings, and very much about the professionals from care homes being able to express some of the problems that they encounter, which obviously, you know, many of us we may have been into a care home to visit family or friends, but lots of people working in other health and care settings have never had the experience of working that. So the exchange of views and experiences is a really important part of the day. And as you can see, there's been some good feedback from the participants around how the days work. The next key part of the programme and the model that we use to understand frailty is a model that I've developed called the Frailty Fulcrum. And this basically is a model that aims to articulate the complex nature of frailty. And it's basically brought in if you like, introduced through a short animation. And in fact, you can now see this animation via the NHS England website. If you look on the news section of the NHS website, I think it was put up around the 5th of January, you'll see an article on the Frailty Fulcrum, which does actually contain a link to the animation. So if you want to know a little bit more about that, please do go on and have a look. So the idea is that this is a model which underpins the holistic approach to the assessment and management of frailty and helps us to understand how different aspects of an older person's life are important in either building up the resilience or creating vulnerability, and how these different things can affect somebody's quality of life. And the real point of it is that it enables care professionals to identify opportunities to improve the quality of life. So it's obviously very important to understand the things that are the sources of vulnerability, but in my view, it's even more important to understand the things that are creating resilience for people with frailty. And it doesn't matter what setting that's in. So whether somebody is in a care home or in an acute trust or in their own home, these things apply to all of us all of the time, and that's very much the messages that run throughout the day. Another key part of the programme is that we've got a supported self-care plan that we've developed. I should have mentioned earlier, but through the development phase of this project, we had an expert advisory panel and we had a user group, so lots and lots of input from the different professionals across the economy about what was important to them and what needed to go into tools to make them practically useful for them. So the idea of this supported self-care plan and the tool that we've developed is to focus very much on what's important to individuals and what's important to people themselves, and how can we, through supporting self-care, help to explore the importance of those different things to help support independence and choice, and also very importantly to understand and accept and manage risk, and to weigh up our perceptions and if you like the management of risk about helping people to achieve the very person-centred aims that they may have for their life and the things that are really important to their own quality of life. As I mentioned briefly before, we've had expert advisory panel involvement and we've had user group involvement, but also very importantly and really tremendously enjoyable, we've had the pleasure and privilege of working with a small number of older people living with frailty and their families and carers to co-design a small number of case studies that we've used within the Toolkit and training programme. So these individuals and their families have kindly shared their stories to allow us to create person-centred case studies that bring to life the principles and the tools, and they highlight the practical application of supporting self-care at different stages of frailty and in different settings of care. So throughout the training event, these are designed to give practical examples and to help people to think about planning and how we can achieve the aims for people. And as I say, it has been an absolute joy to be involved. So the next, moving on from the case studies, another key feature of the programme is that we have developed a virtual reality frailty simulation. Now, the background to this is that during a piece of work that I was doing in the emergency department, we had an older people special interest group, and some members of our team had been on a training day where they'd had the opportunity to use an age simulation suit, and they found that really, really helpful, and we subsequently obtained one of an age simulation suit to use within our training work in the department. The only challenge with that is that it's not a very scalable approach because it takes quite a bit of time to get it on and off individuals, and so we came up with the idea that if we could maybe exploit some of the new technology to create a virtual reality version of the age simulation suit, then that might help us to generate some discussion, to help people to empathise and to understand some of what that experience might be like and some of the challenges that exist for people who are living with frailty. So we've developed a short virtual reality simulation which we've been using in the training programmes, and it's been really well received, and it's been a very interesting addition to the programme, and it certainly has generated a lot of discussion, not only about helping to develop empathy with the people that we're caring for, but also about helping to build awareness and observational skills, and it does fit in the context of the case-based work that we do in the programme. So in terms of how's it going so far, we've had So far we've had around 200 people through the training days. We've got another series of training events starting next week, in fact, and by the end of that we'll have had around 400 people through the programme in the last few months. These people have come from over 20 different organisations and from more than 40 different professional roles. So it's been really enjoyable and really tremendous to get the opportunity to share those opportunities. And interestingly, in the feedback, it is that opportunity to network, to work in a multi-agency way and to meet people that they would never normally be able to meet, that has been rated very highly by the participants. In terms of accessibility for people working in care homes, and we certainly have had a good number of people from care homes who've attended the events. So far, I think maybe around 10 or 15% of the participants have been from care homes. Obviously, it is quite challenging sometimes for people to get away to be able to attend a full-day training event, and that's something that we're looking at addressing in the next phase of the programme. So lots of really good input, lots of interest. It is a long and intense day, and that's really been the only thing that some people have commented on in terms of, is it possible to make it a shorter day or not quite so intense? But then again, there's a lot to get through, and that really has been a handful of people who've made that comment within the 200 or so people that have been through the programme so far. At the end of the event, we ask people to think about the goals and what they're going to do as a result of the training day, and we are just about to send out next week the follow-up questionnaire to find out how the people who came through the October events have managed to follow up on those goals and how well they feel they're getting on with them. And you can see on this slide some of the things that people have been talking about and some of the things that have prioritised as their goals and what they want to do with the results of the training that they've been through. And I won't go through them. You can look them at the slides afterwards, but you can see there's a good range of things that people are intending to go away and do. Also, we've got some information in terms of collecting the information that people have given us around the helps and hindrances in their ability to support self-care in their daily lives. And you can see that available capacity is by a long way the biggest challenge. Really, that's across all areas and all sectors, but also lots of positives too. People talking about understanding each other's roles, about working together in more integrated ways. And you can see there's a range of different challenges and opportunities that have been identified by the teams. And the idea with this information is that through the training events, we're obtaining this feedback directly from large numbers of frontline staff, and this is being fed back through the steering group and the stakeholder groups to try and support the system leaders to create more opportunities to help people work in this way. Very briefly, the biggest challenges from the programme so far, as I've already mentioned, sometimes operational pressures make it difficult for staff to get to training, and obviously there is a very large number of health and care providers across the area that we're looking at. And also we have had some technology issues. We have identified that quite a number of the health and care providers are on quite out-of-date operating systems, and so that has created some problems in access to the toolkit, but that's pretty much resolved now. We've made some good progress in that area. Very briefly, what we're planning to do next is to develop shorter modules that will allow people to access these the same materials but through different formats in case they're not able to attend the full-day training events. And we've got, in a couple of weeks, we've got the first of a short modular approach to raising awareness of frailty and supported self-care, which we're rolling out in 2-hour training sessions through a training event that's being run by the council. And we're also modularising the case-based training session as well. As I say, lots of information about learning as we go. There's been lots and lots of feedback from the participants, and we've got lots of opportunities really to look at developing this approach and how we can really widen out access to the toolkit and to track and understand which parts of it are really useful to people and which parts we might be able to add more to it to improve the benefits. So really it was a programme that's all about integration. It's about working across a range of people involved in health and care. It's all about working with individuals, both frontline care and individuals, but also the individuals for whom we're trying to design these services. And we've tried to take an innovative approach using the latest technology to not only make the training more interesting and engaging, but also to make it more scalable and accessible to a wider range of professionals. And that's the end of my presentation, but of course I'll be delighted if there's any questions that anybody would like to raise. Thank you very much.
Brilliant, thank you. Wow, what a huge, vast number of people we've got with wonderful expertise. I mean, I have to say I'm very impressed, and the pace that you've managed to get through all of the information is impressive. So thank you very much. And well, I just turn to our audience and say, you know, now is really your opportunity to have an open conversation and dialogue with the presenters and just understand some of the things you've been doing, some of the approaches you're taking, some of the challenges, and learn from what these vast, you know, expertise that you've got available to you, which you don't routinely have all day, every day. So please do take this opportunity to have a think about that. Some interesting discussions on Twitter as well. So those of you who are on Twitter might want to follow those conversations too. So just turning back to our presenters again, I'm not quite sure who wants to answer it or whether you all want to look at it from a different perspective. But one of the questions that we that's come through on Twitter is around medicines management or medicines optimization, I guess, and is around care home residents taking a median of 9 medications, and asking the questions about regular drug reviews and how that I guess, not only as professionals you might have an opinion, but how the toolkit applies and supports and helps that. So I don't know who wants to answer first, but your lines should all be open for you to speak.
I mean, just to pick up on that question, in the quick guide, there's also reference to a project that I was involved with through North Staffordshire CCG, and that was a project around an enhanced primary care service for care home residents in North Staffordshire. And a very important part of that was the medication reviews. We had a really excellent care home pharmacist who worked with us on that project, and that was part of the specification, was that we recognised that, if you like, the standard medication sort of review schedules, if you like, that were, if you like, part of routine primary care, just weren't really enough for this group of patients, and that actually residents would benefit from much more regular reviews of their medication. So we had an enhanced schedule of routine medication reviews, but we also had particular trigger points that would trigger an early review. So, for example, we identified that there were particular risks when people had been in and out of an acute hospital admission, because very often people would come home on different medication, and that wouldn't necessarily have been fully reconciled with what they were on before and things. So yes, absolutely. I mean, I completely agree. It's a really, really important point. It's an area where it is possible to make a really massive impact, and certainly there's quite a good body of evidence out there now to support that approach.
Brilliant. Agreed. Does anybody else want to comment?
So I'd just like to say something that it was something that we worked with care homes to talk about how important medication management was, and in response to that, what we've hoped to do is actually bring in community pharmacists into the fold of care homes, and also encourage GPs to do drop-in clinics once a week within the care home, so that they can regularly look at medication and decide whether the particular person needs it, and also challenging nurses themselves and care staff. So, you know, the routine use of lactulose, I mean, what's that about? You know, that sort of thing. So it's still quite embryonic, but the care homes we've been working with have actually realised, you know what, often we just give the medication and we actually don't think, is it really needed? So the homes that have introduced GPs doing weekly drop-in clinics, may well not be that that particular person needs a review, but what they can do is talk about the medication with the GP, especially if someone's really overly sleepy, that sort of thing. So actually matching how the resident is with what the medication that they're receiving. So it's still quite embryonic, but we've found that they particularly like looking at them sort of things.
Yeah, there was some really good work done around a call to action for people with dementia around, you know, the intolerable act of some of the medicines that they were on, and how they were actually causing them to be sleepy rather than enabling them to live their life. And I think, you know, for everybody, this is probably quite a key issue that can, you know, correct a few, you know, parameters to enable us to live life well and happy. So that's a really good point. Thank you. I'm just going to bring in one of my team who's been doing some work very near your patch, Dawn, and was up there yesterday with what we deliver as a staff-facilitated workshop, using the House of Care as a framework, you know, the 4 components of it, and trying to understand where their challenges are, where their strengths are, where they're really shining, and where we can probably best support them from our skill base, which is delivering improvement expertise. And their focus yesterday was on frailty, which is of interest, and we might connect you, Dawn, separately. But I just want to bring Lynette into the conversation, who perhaps has some thoughts about how she could use that tool with her site.
Thank you.
I just really wanted a bit more information on that. Can anybody access Toolkit for a charge for it? Is there any sort of it sounds like a really good tool that the site might use in creating a new frailty service, and that's what they based their star around yesterday, so that they sort of pinpointed where they sort of saw the direction of travel. And I do think that this toolkit would be of interest to them.
So Nicola, I don't know if that's a question for you. Is it free? Can anybody access it? So Nicola, yours is free and open access to everybody. That's a quick guide. And Dawn, yours is free and open access to everybody, or not?
Not currently, because it's been
okay.
Because basically it's been commissioned through HEME, and obviously it's been, at the moment it's built where you get to log in and you need a login and a password. The reason being really because it's still, I suppose, still essentially in a sort of pilot phase at the moment. But actually that's one of the next, which I didn't really have a lot of time to talk about at the end, but that's one of the issues that we've been talking about, is how can we make it much more openly available, and making sure we've got the infrastructure behind that in terms of the technical support and things, because and because also not only is it obviously helpful to a wide range of health and care professionals, but actually there's a large amount of material in there which would be really useful to individuals themselves and to informal carers. So that's really part of phase 2 of the project, which we're hoping we'll be able to have some developments on soon.
I really like the idea of the simulation. I think that looks really fascinating.
It's really good fun, actually. It's gone really, really well, yeah. And people have, I mean, it's been fun, but it's also been, you know, we've obviously, because it was a new innovation, we've done quite a lot of detailed feedback looking at that, and looking at the particular aspects of it and how it works and which are the most valuable bits. So yes, it's been very, very interesting.
I can imagine. It's the insight. The nearest I've got to that is some ethnography work we did around walking in people's shoes and seeing the impact. But that's not the same as feeling it for yourself, or going through it yourself. So I might come and have a little play at that.
Oh, absolutely. You're very welcome.
Yeah, no, that sounds good. Okay, so we've gone a little over our time. So I am going to call this to a kind of summary close now, just because people will have other commitments this afternoon. But that's been a really fabulous discussion. So before I just thank our audience, I just want all of the presenters just to have a quick think of what is it that you want people on this call to go away and do instantly. You know, what's the thing that they can do today rather than the ambition of 5 or 10 years' time? So just have a quick think about that. Just turn around to our audience. Thank you very much for your patience and your time in dedicating to this subject. It's clearly something that is going to become increasingly more important. So I think what you've heard today is really well positioned for how support for care homes moves forward into the future. So I think that's really important. And just really do share with us what you take from this in reply to the email we sent this afternoon, or very quickly in the chat box. What is it you're going to do, and how can we start to create a little action learning set of people who are interested in this topic and doing things, because I just get a feeling people like Angela on this call might well really want to hear what you're up to and how you're using the tool, and what can they in Angela's team and in Nicola's team actually learn from your practical application experience of it. So please do stay connected. So to turn back to our presenters, thank you so much. I mean, there's a comment in the chat box, I don't know if you can see it yet, that just says thank you for all your time and energy with all the presentations. My head is buzzing now, and that really does capture how I feel as well. So thank you for that. And just to turn back to you each individually and just ask you for what's the one thing you want people to do the minute they end this call?
I think for me it's really all about really that we can be so positive about the opportunities in frailty, because I know it can, certainly from a clinical perspective, it can feel quite daunting and overwhelming, you know, whether that's on a professional perspective or all of us no doubt have got family and friends and other people that we care for who are living with frailty. But I think take the opportunity to think about the positive things, you know, in those people, in people's lives, and the great opportunities we've got for promoting resilience, whilst recognising that there are challenges around vulnerability, but let's think about the positive side of things and maximise those opportunities.
Angela.
What I would say is see care homes as your friends. I think I'm a nurse, and I think most importantly we need to understand that there's absolute excellence going on in care homes. In fact, sometimes there's more excellence in care homes and nursing practice than what's going on in an acute hospital. So I would say be sighted on your care homes, treat them with respect, try and engage with them and see them as part of the bigger system, and they are a solution. They're not the enemy. They really need to be helped and supportive. And to be honest with you, it's not being I've been pushing at an open door. Everyone's just been so engaging with me. So I just like to say, I think that we should just really look at care homes in a different light as well, because they are part of the solution. That's what I would say.
Brilliant. Thank you. Emily?
Well, I would say thank you very much for, I think it's been so interesting listening to Dawn and Angela. It's just amazing. And I would say in terms of what people can go away and do, please go online to NHS Choices and download the quick guide. Have a look through, see if there's anything there that you could implement quite quickly. There's loads of things that you can just quickly download and borrow. And also there is a care homes network which has been set up quite recently on the Better Care Exchange. And I'm going to put the, literally just pinging that round now to everybody. So please do log on there, join the network. It's a great way to continue this conversation, to share ideas, and also to share some of the work that you've been doing.
It's a really good opportunity. Thank you, Emily. That's really helpful. And finally, Nicola, who's done all the work in coordinating your presenters for today. So, Nicola, who opened our session, I'm going to leave it with you to close it with your thoughts.
Yeah, no problem. Thanks, Bev, and thanks everybody for listening. So again, just to reiterate what Emily said, really, just any help with kind of circulating the quick guides would be really useful. And then also feedback on whether you've implemented any of the initiatives that are mentioned in there as well. We're always looking to hear about work that's been passed on. So thank you, everybody.
Brilliant. Thank you, Nicola, and good afternoon to everybody. And take the products and make use of them. So thank you very much indeed. Goodbye.